بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. أعزائي طلاب وطالبات المستوى الرابع بكالوريوس طب وجراحة الفم والأسنان، أهلا بكم في مستهل اللقاء أو الحلقة التعليمية الثانية عشر ضمن مقرر طب الفم. في هذا اللقاء سنواصل الحديث عن Oral White Lesions Part II. In the last lecture we had talked about 4 of the most presented white lesions in the oral cavity, started with lichen planus, lichenoid reaction, lobus erythematosus, and also we had talked about the chemical burn. We had talked about those 4 lesions regarding their clinical features, their differential diagnosis, their final diagnosis, and their management. We'll continue about the white lesions as a part 2 white lesions for the 12th lecture. The references of this lecture: Handbook of Oral Medicine and Burkitt's Oral Medicine. At the end of this lecture, the student should be able to differentiate the clinical findings of white lesions with the other oral lesions, and also should be able to diagnose the lesions which is presented in the oral cavity as a white lesions and correlate their causes and risk factors with the differential and definite diagnosis. And also at the end of this lecture, the students should be able to reach the definite diagnosis for those white lesions and provide the best management for those lesions, and also should be able to integrate the clinical findings with the systemic condition and the present complaint of the patient. In this lecture, we will talk about many of white lesions, starting from Pseudomembranous Candidiasis as an fungal infection which presented in the oral cavity as white lesions, and also we called it oral thrush. And also we'll talk about the chronic hyperplastic candidiasis, which is another fungal infection presented in the oral cavity as a white lesion. And also we'll continue talking about other lesions such as white spongy nevus and keratosis congenita, which are hereditary white lesions. And also we'll talk about other white lesions such as frictional keratosis, nicotinic stomatitis, and also the smoker keratosis, the same name. And also we'll talk about the Leukoplakia, submucous fibrosis, as well as biostomatitis vigitans. All those white lesions, we'll talk about them in detail, starting from the etiology and the pathogenesis of those lesions. And also we'll talk about the clinical feature of all of the white lesions presented in this lecture. And also we'll talk about their investigation, differential diagnosis, and the final management procedure for each of these white lesions. The pseudomembranous candidiasis, the first one, also can called as an oral thrush or candidiasis. The majority of these cases are caused by fungal infection, which is the Candida albicans. The age is important factor in the development of oral candidiasis, so more commonly present in the age extremities. So the older, the most older, and the most younger patients. The presence of iron deficiency also are associated with pseudomembranous candidiasis. We can call it also cytopenia, so leading to thrush in the adulthood, as well as the presence of HIV infection or antibiotic or steroid drug therapy if the patient is under long-term treatment by antibiotic or long-term treatment by steroids, can be presented with oral candidiasis. So these drugs can disrupt the oral microflora equivalence. Soft creamy yellow patches are the clinical appearance of candidal infection that affect large areas of the oral mucosa, and these plaques can be webbed off. So if you use a piece of gauze and try to web these white patches, it can be rubbed off. So after removal, reveal underlying erythematous base. Differential diagnosis: chemical burn, traumatic ulcer, necrotic ulcers. The diagnosis of candidiasis: smear of suspected thrush. The oral thrush can be diagnosed by using a smear or taking a smear layer from the lesion and stain by gram stain or periodic acid shift reagent to demonstrate large members of fungal hyphae and blastospores. So you will see the Candida albicans fungal hyphae. A swab or oral rinse can be taken and sift for culture. So you can use a swab or instruct the patient to rinse and spit off the sample. The management of the oral thrush is use of topical agent such as amphotericin or nystatin or Mucosal, which is an antifungal drugs. The new generations of antifungal such as fluconazole, itraconazole are also extremely effective within 7 to 15 days to treat those lesions. The underlying factors such as cytopenia or HIV diseases or the patient who is under long term of corticosteroid treatment or antibiotics, all these factors should be eliminated to permit the oral lesions to resolve. The second lesion is the chronic hyperplastic candidiasis. Chronic hyperplastic, so it is chronic, developed long period of time, and hyperplastic, so there is a hyperplastic lesions, and so it's called a Candida Leukoplakia. The etiology and pathogenesis similar to Pseudomembranous Candidiasis and particularly related to tobacco use. So those patients are commonly practice smoking or chewable tobacco habit. Clinically, the Candida Leukoplakia presented as a thickened, irregular or smooth white plaques, as we see in the clinical picture, most frequently at the commissures of the mouth and the dorsal of the tongue. The white plaques does not rubbed off. This is the only type of the candidiasis or the candidal infection of the oral cavity which cannot be rubbed off. The Pseudomembranous candidiasis cannot be rubbed off. The oral thrush, as we mentioned, also can be rubbed off. This form of candidiasis may occur in mucocutaneous syndrome. Differential diagnosis of Candida Leukoplakia is the hairy leukoplakia and white sponginovus and the leukoedema, as well as the proliferative verrucous leukoplakia, also similarly presented in the oral cavity with the clinical features of Candida Leukoplakia. The diagnosis: mucosal biopsy will reveal the definite diagnosis, should be so performed, and you will find the candidal hyphae as a evidence of the causative factor Candida albicans, and you will find keratin layers and hyperplastic epithelium with chronic inflammatory cell infiltrates. This is the histopathological findings of Candida Leukoplakia. Management of Candida Leukoplakia: systemic antifungal agents leading to clinical and histological resolution after 2 to 3 weeks. For persistent lesions, you need to perform a surgical excision for these lesions, especially if there is a signs of epithelial dysplasia, and tobacco habit should be stopped since the lesions are likely to recur if smoking is not eliminated. So if the cause is presented and the patient continue his or her habit, the recurrence of the lesion will be occur. The third lesion of this lecture is the white spongy nevus. This white spongy nevus is a hereditary benign condition with an autosomal dominant. Is due to a point mutation of keratin 4 and 30 genes. So it is a genetic inherited condition related to 4 to 13 gene mutation. Clinically, we will find a deeply folded white lesions at several mucosal sites, so it is widespread, particularly in the buccal mucosa, the most common site. The other site in the body may be involved, including the mucosa of vagina and vulva, and also the anus esophageal mucosa also might be presented with white spongy nevus. Also, it is developmental in origin. The white spongy nevus cannot be appeared, as you can't find it until the second decade of the patient's life. Differential diagnosis: cheek chewing or cheek biting, leukoedema, leukoplakia, and lichen planus. Diagnosis: the diagnosis is firstly made on the clinical findings and the clinical presentation of the lesion, which cannot be rubbed off and widely spread in many sites in the oral cavity, most commonly the buccal mucosa, and also the history of the lesion appearance at the second decade of life of your patient, and also if there is any other member of the patient's family complain from this inherited lesion. The biopsy will show hyperkeratosis with edematous keratinocytes, and we will see a prenuclear condensation of keratin. There is no epithelial dysplasia, so it is a benign condition. How to manage white spongy nevus? No treatment is required since it is a benign condition and it has no malignant transformation potential. The fourth lesion is the dyskeratosis congenita. Dyskeratosis congenita is also an inherited syndrome in which patients undergo premature aging as well as predisposition for malignancy. So the gene responsible for X-linked dyskeratosis congenita encodes protein which is called dyskerin gene. So the white spongy nevus and the dyskeratosis congenita shared the same information, which is both of them are inherited and associated with gene mutations. The clinical features: the manifestations become evident in the first 10 years of life, but the white spongy nevus presented in the second decade of life. This is the first decade of life. Reticular skin pigmentation can be found in the oral cavity and in the upper chest with dysplastic nails of the fingers, and also it is all these characterize the cutaneous manifestations of dyskeratosis congenita. The mucosal erosions and areas of leukoplakia will be found in the oral cavity and are potentially malignant. So this lesion, dyskeratosis congenita, is associated with premalignant transformation, in opposite to that of white spongy nevus, which is benign and have non-malignancy transformation. Approximately 30% of the leukoplakial lesions progress to oral cancer. So as we mentioned before, it is associated with malignancy transformation, rapidly progressing periodontal diseases, and thrombocytopenia. Aplastic anemia may be also associated with keratosis congenita. This is the clinical appearance of keratosis congenita. Diagnosis of keratosis congenita depend on the history and clinical presentation mainly. If the biopsy is performed, it will be non-specific character, showing hyperkeratosis, epithelial atrophy, and severity of dysplasia. Management of keratosis congenita. First, the condition is managed symptomatically, so you will treat the symptoms of your patient. Careful observation of the oral mucosa, biopsy of suspicious areas, so it is associated with malignancy transformation. It is very important to perform a biopsy of any suspicious areas to rule out any type of malignancy transformation. The systemic manifestations also are managed medically by referring the patient for the specialized physician. Differential diagnosis of keratosis congenita, Candida Leukoplakia, and white sponge nevus are the two lesions which are clinically very similar to keratosis congenita. The next lesion is the frictional keratosis. Frictional keratosis, from its name, due to friction of the oral mucosa, so causing a chronic irritation of the oral mucosa. It's an analog to a callus which forms on the area of the skin that chronically rubbed as the sole of the feet. So if there is any area exposed to chronic irritation, friction, so a callus will be formed. So in the oral mucosa, keratosis will be resulted. The most frequent cause of irritation in the mouth is the trauma and chewing. Any site in the mouth can be affected by frictional keratosis, the most common site being the lips and lateral border of the tongue and the edentulous ridge, which chronically exposed to friction. The lesion may be well demarcated or diffuse depending on the cause of the friction. If the cause of friction is, for example, cut chewing, so the frictional keratosis will be widely spread, diffused on the buccal mucosa on the chewing side. If the cause is a sharp cusp for the tooth or malformed restoration, so the frictional keratosis lesion will be localized, well demarcated. The surface is homogeneously white but may have a thickened corrugated appearance. The diagnosis of frictional keratosis depend mainly on the clinical diagnosis and the medical and social history of the patient. A biopsy often needed to confirm the diagnosis and rule out any malignancy transformation or any other inflammatory process. Microscopy of a biopsy taken from frictional keratosis will show hyperkeratosis without any type of dysplasia, and the scattered chronic inflammatory cells also will be presented in the underlying connective tissue of that lesions. Management: removing of the cause is the key treatment or the key management of chronic irritation. So if the patient is a cut chewer, you should advise him or her to stop the habit. If the patient had a malformed restoration, filling or bridge or whatever, you should remade and correct this malformation. If the patient has the habit of cheek bite, habitual cheek biting, you should ask him to prevent this and stop this habit. The rough surfaces, as we mentioned, should be corrected, and also the other causative factors should be managed. Sometimes the provision of acrylic guard when the patient complaining from cheek biting, or what we called it a night bruxism, should be protected by acrylic guard, or what also we called it night guard, to prevent the night cheek or lip biting. There is no evidence of any chronic trauma along the alone predispose the development of malignancy, so the patient which can be developed with a chronic with malignancy commonly associated with other risk factors for malignancy transformation, such as smoking and cut chewing, and other causative factors such as sun, X-ray, or malnutrition, or other risk factors for malignancy. The other lesion is the nicotinic stomatitis or smoker's keratosis. So from its name, due to nicotinic releasing from smokers patients, most frequently occurring due to tobacco related keratosis in the mouth, can be associated with pipe, cigar, or cigarettes. So all the types of smoking can be resulted in nicotinic stomatitis. The hyperkeratosis of nicotinic stomatitis is reactive to heat generated by tobacco product, and also the chemicals which are presented in the smoked tobacco. Clinically, nicotinic stomatitis, characteristic site of nicotinic stomatitis is the involvement of the hard palate. As we see in this clinical picture, there is a wide patch with pinpoint red dots. These red dots represent the minor salivary gland. Duct openings. So it is inflamed minor salivary gland duct openings due to the effect of the heat and the chemicals presented in the smoked tobacco. Although predominantly white, there are erythema with punctuate red dots, as we mentioned, representing the inflamed minor salivary gland duct orifices, as we mentioned. The diagnosis of nicotinic stomatitis depends on the history of tobacco use and also the clinical appearance of the lesion. Biopsy is not usually indicated since the risk of neoplastic transformation is very low. Management: at first the patient should discontinue all types of smoking, pipe or cigarette or whatever. It's important to, if the tobacco usage, this keratosis, nicotinic stomatitis, it is very important indicator for tobacco usage. So you can, if the patient lied for you and he does not speak the facts or the real about his habits or her habits about smoking, you can find these clinically indicative findings to smoking. So may indicate the risk of dysplasia and also neoplasia and other susceptible sites. So if you find nicotinic stomatitis in the hard palate of your patient, you will check his tongue, his buccal mucosa, his or her vestibules, to find out any dysplasia or neoplasia at these other susceptible sites for oral malignancies. Leukoplakia. Leukoplakia, as we know, it's a clinical term used to describe white patch or black on the oral mucosa that cannot be rubbed off, and we can't characterize this clinical lesion as any specific disease. So we can characterize this finding, which is a white patch or black, to any other specific disease. So we will call it a leukoplakia. Most of the cases of leukoplakia are associated with tobacco habits and the alcohol hematinic deficiency, such as what occur in Plummer-Vinson syndrome, and also chronic trauma may play a role in the development of leukoplakia lesions. In the developed countries, the transformation rate of leukoplakia to oral cancer is low, about 1 to 2% in 5 years, but this may increase in the Indian subcontinent, about 15 to 20% of the Indian subcontinent are associated with malignancy transformation of leukoplakia lesions. Most of the cases of leukoplakia occur in the middle-aged and also in the older populations. The most common sites of leukoplakia development is the tongue, lower lip, and the retromolar regions, and the floor of the mouth. Leukoplakia in the floor of the mouth has a higher rate of malignancy transformation than other sites. Clinically, leukoplakia may have a range appearance from flat white patches to wart-like lesions, and also it can be presented as a thickened leathery patches to mixed white patches, which called a speckled leukoplakia. The speckled leukoplakia are a white leukoplakia lesions with red dots or mixed with erythematous dots or white. We can call it a speckled leukoplakia, which has the highest malignancy transformation. Diagnosis of leukoplakia lesions depend on the biopsy, which is mandatory, since there are many of the lesions similar to carcinoma in the clinical appearance. In addition, it is essential to determine the severity of any epithelial dysplasia that may be present, so you will perform a biopsy, and which can reveal a mild, moderate, or severe types of dysplasia, or even a carcinoma in situ. Then, if there is an absence of dysplastic changes, no treatment of the leukoplakia is required apart from periodic re-examination. So we will emphasize on the re-examination periodically every 6 months to rule out any development of any dysplastic changes. If these lesions presented with dysplastic changes proven with histopathological findings, this will depend, its management depend on the severity of epithelial dysplasia. In mild dysplastic leukoplakia, you can manage it conservatively with emphasis on the elimination of the cause. So from the history you will find the cause of this leukoplakia lesion and advise the patient or instruct the patient to stop his or her habit. This when you find by the histopathology a mild dysplasia. If you perform a re-biopsy after 3 months, you need to assess the effect of the measures you had performed to your patient at the correction of the etiological factor. If the biopsy reveal a severe dysplastic changes should be managed as a cancer, and the patient should refer to maxillofacial surgeon to remove this lesion and treat it as a cancer due to the risk of malignancy change. The other lesion is the submucous fibrosis. Submucous fibrosis, one of the most important pre-malignant lesions due to development of fibrous tissue in the buccal mucosa and the palate of the patient. And the primary causative factor, the primary etiological factor of the submucous fibrosis is the chewing of betel nut, which is a common habit in the Indian population. The chronic exposure also to chili peppers and also prolonged deficiency of iron and vitamin B complexes, particularly the folic acid, also an etiological factors for development of oral submucous fibrosis. In addition, excessive production and insufficient degradation of collagen by fibroblast leads to development of oral submucous fibrosis. Clinically, this lesion most suffers presented with the age of 20 to 40 years old at the time of presentation. The clinical character of oral submucous fibrosis characterized by irregular flat white lesions which develop in the mouth, particularly in the buccal mucosa and the soft palate of the patient. Also the esophagus and the pharynx can be also affected. The most striking feature of the oral submucous fibrosis is the formation of marked fibrous bands that can be palpated in the clinical examination in the cheek and the soft palate. So it is very important to perform a good clinical examination, digital examination, and palpate the underlying tissue of these lesions to find out the fibrous bands, which is the characteristic of the oral submucous fibrosis. Diagnosis is depend on the manual detection, the digital palpation, digital examination of the fibrinous bands within the mouth and the associated trismus. So these lesions can be associated with trismus. The patient can't open his or her mouth due to the development of the fibrous bands on his buccal tissue. The biopsy often worsens the condition but may be necessary to determine if there is white lesion containing epithelial dysplasia. It's very important to differentiate this condition from fibrosis and scarring secondary to injury. So it is very important to take a very detailed medical and dental history from your patient to rule out any history of trauma or surgery which can lead to scar. The scars can resemble the bands of or the fibrous bands of oral submucous fibrosis. In addition, it is very important in the management of this treatment is to discontinue the habit, which is the areca nut chewing. For the patient with restricted opening, manual stretching exercises should be performed to reassuring the mouth opening of the patient. Steroid injections inside the fibrous bands also can be helpful to degrade the fibrous bands. In addition, the enzymes that digest the fibrous tissues, such as chymotrypsin as well as hyaluronidase, also can be helpful to be injected directly in the affected tissues, leading to degradation of the fibrous band of these lesions, and the patient must be reviewed closely, and approximately 1/3 of the patient associated with submucous fibrosis will develop an oral cancer. As we mentioned above, it is the most important white lesion which can be associated with high grade of malignancy transformation. The other white lesion is Biostomatitis vigitans. Biostomatitis vigitans is a chronic pustular mucocutaneous disorder. So it is bio means pustular, so there is a pus formation, often seen in association with inflammatory bowel disease, which is a systemic condition of GIT, such as also the Crohn's disease and ulcerative colitis. These Crohn's disease and ulcerative colitis are an examples of inflammatory bowel diseases. The cause of oral mucosal lesions is until now unknown. Clinical feature of Biostomatitis vigitans, first of all, can occur anywhere in the oral cavity, but is seen most frequently on the labial or the buccal mucosa. The erythema progress to tiny yellow pustules, and here I should ask you, what is the meaning of pustules? As we studied in the lecture of the clinical prescription of the lesions. So if you remember, the pustules is a pus containing vesicles or bulli, so containing a pus. So erythema progress to tiny yellow pustules measuring 2 to 3 millimeters in diameter. Males affected twice frequently as females, and the condition is most often seen in the 3rd to the 6th decade of life. Diagnosis of Biostomatitis vigitans depend on the clinical examination and the history of the inflammatory bowel disease. And so we will also repeat our emphasizement about the medical history of the patient. The medical history of the patient. So you need to take a detailed clinical examination and thorough medical and dental and other types of history. So the medical history will help you in the diagnosing some lesions. Diagnosis is more difficult to achieve in 25% of patients who have no any bowel or GIT diseases. The biopsy of oral mucosa is unfortunately non-specific, showing chronically inflamed mucosa, superficial abscess, so we called it biostomatitis, and ulceration as well as necrosis. Management of Biostomatitis vigitans started with successful management of bowel involvement, so you need to refer your patient for GIT specialist, and this management of the systemic condition will associated with improved oral lesions. The oral lesions can also be treated with oral antiseptics, so there is an ulceration of the pustules and pus secretion. Local corticosteroids can be also useful, and systemic administration of antimicrobial agent and metronidazole to manage the infection. In conclusion, through this lecture we had talking about many of the white lesions, starting with Pseudomembranous Candidiasis, oral chronic hyperplastic candidiasis, white sponginovus, and keratosis congenita, as well as frictional keratosis and nicotinic stomatitis, and the leukoplakia, submucous fibrosis, and Biostomatitis vigitans. The assignment of this lecture is the student should be present a clinical cases of any of white lesions, and this assignment also with its explanation will be provided in the assignment section as a Word document under title of assignment 12. Thank you very much, dear students.